So, hello everyone. We are here. Must know MCQ in pediatrics. Yesterday we covered some very good MCQ about murmur. Yes, today something more. Yes, something more I bring for you today. So yes, myself Dr. Sanjay Khatri, your pediatric educator. So something about Unacademy. What's new is coming. So yeah, NEET PG 2023 All Educator Ultimate Revision Batch. Join this and feel the difference. Duration 6 months. It's responsibility of all educator to give you the best. So join it. Yes, one batch of FMG is already running on from 26 September. To boost your preparation, you can still join this batch. Now, Question Bank 2.0, Unacademy team working since so long to give you the best. So, avail this question bank. For that, you need to enroll in Unacademy. 20% discount till 30th September. You can use any code or my code Dr. Sanjay Live to get some additional discount. So this is about basic introduction, upcoming courses, and yes, we are here. Must know MCQ. Sometimes we know the things. Like yesterday class, I told you murmur. The murmur MCQs we left because we done CHD everywhere. So some topics in hemato. We read bleeding disorder, ITP, Bernard-Schuller, Discott-Eldridge syndrome, hemolytic anemia, thalassemia, sickle cell anemia, iron deficiency anemia. So something we leave, some between. So yeah, it is there. Approach to coagulation disorder. Approach to coagulation disorder. If child comes to you, mucosal or skin bleed. Mucosal means epistaxis, GI bleed, menorrhagia, skin bleed, petechiae, purpuric patches, ecchymotic patches. Yes, it's a platelet disorder on the first. But if child comes to you, muscle or joint bleed, IM injection. Normally, lot of children get IM injection, but this baby, hematoma occur. Joint bleed, fall on the road. So many children fall on the road daily. But in this child, hemarthrosis occur. If muscle or joint bleed is there, you feel something wrong in clotting factor. It's a clotting factor disorder, coagulation disorder. If child presented to you muscle and joint bleed, sometime coagulation disorder is also suspected whenever there is late post-op bleed. Late post-op bleed. Surgery over, late post-op bleed occur. No problem in sutures line. Still bleeding is there. Some coagulation disorder may be there. Some factor deficiency may be there. So what is our approach? What is systematically approach to a coagulation disorder? See, you can appreciate very well hemarthrosis, bleeding in the joint, bleeding in the joint, bleeding in the joint. So if a child comes to you bleeding in the joint, bleeding not controlled easily, history of frequent bleed also, after minor trauma, so yes, we are thinking it's a coagulation disorder. For coagulation disorder, we need to check PT and APTT. Now, both these PT, prothrombin time, APTT, activated partial thromboplastin time. If PT increase, it's factor 7 deficiency. If APTT increase, it's either 8, 9, 11 or 12 deficiency. Clear? If only PT increase, it's factor 7 deficiency. If APTT increase, either 8, 9, 11 or 12 deficiency. 8 deficiency, hemophilia A. 9 deficiency, hemophilia B. 11 deficiency, hemophilia C. What is the classical about factor 12 deficiency? What is the classical about factor 12 deficiency? APTTs increase. It is because of factor 12 deficiency, but there is no bleed occur. No bleeding. Suppose pre-anesthetic checkup, incidentally you detected APTT is prolonged. So you postponed the surgery. Why APTT is prolonged? But you come to know it is due to factor 12 deficiency. Then no chance of bleeding. Now, only PT prolonged in early vitamin K deficiency. Early vitamin K deficiency. Early vitamin K deficiency, only PT prolonged. Now see, if both are prolonged, PT as well as APTT. If both are prolonged, then you are dealing with 2, 5 or 10 factor deficiency. If both are prolonged, it is possible in late vitamin K deficiency. So go slowly and slowly. If only PT prolonged, it's factor 7 deficiency. APTT prolonged, suppose during pre-anesthetic checkup, boy, APTT prolonged, postpone the surgery. Why APTT is more than 200? You need to find out 8, 9, 11, 12 is any factor deficiency. So APTT prolonged, just alarm is there. 8, 9, 11, 12 deficiency. Both prolonged 2, 5, 10 or late vitamin K deficiency. Now PT and APTT slightly prolonged, but main culprit is TT. Thrombin is time is prolonged. So what you suspect? APT and APTT slightly prolonged, but main culprit is TT. Thrombin time prolonged. It is defect of fibrinogen, either afibrogeninemia or dysfibrogeninemia. Afibrogeninemia or dysfibrogeninemia. Okay, suppose all are prolonged. All are prolonged. All PT, APTT, TT, bleeding time, all are prolonged. It is DIC. It's so common. Now it's expire. This question is so common. Asked so many times in previous exams. All are prolonged. It's DIC. Now, very important. Bleed continue. Whether it's a post-operative bleed or it's joint bleed. Bleed continue. All normal. All normal. Means PT, APTT, TT, all normal, but bleed continue. What do you think? Anybody in the comment box? It is factor 13 deficiency, which is diagnosed by urea clot lysis test, which is diagnosed by urea clot lysis test. Am I clear? See this flow diagram. Only PT prolonged, factor 7. APTT prolonged, 8, 9, 11, 12. But the MCQ about 12, if 12 deficiency is there, there is no bleed. Both prolonged, 2, 5, 10. Only TT prolonged, it's a defect of fibrinogen, afibrogeninemia or dysfibrogeninemia. All are prolonged, it's DIC. Bleed continue. So definitely you will do PT, APTT, TT, everything is normal, but bleed continue. Then it is factor 13th deficiency. It is diagnosed by urea clot lysis test. Diagnosed by urea clot lysis test. So this is the basic. If you remember this flow diagram, na, so many questions are there as it is. If only PT prolonged, factor 7 or early vitamin K. APTT prolonged, 8th, 9th, 11th, 12th deficiency. ABC in 12 deficiency, no bleeding. If both prolonged, 2, 5, 10, late vitamin K deficiency. Main culprit is TT. If TT prolonged, afibrogeninemia, dysfibrogeninemia. All prolonged, DIC. All normal, but bleed continue. Factor 13th deficiency, urea clot, lysis test. Clear? Now, once we read the things, now we will do applications. What we have read, we will find out it by application. We will do application. Let's see. Can you answer this question? I want answer in the comment box. Yes, Amit, Arita, Akshay, you can answer this question. Just use the basic which we already read. A 4-year child having profuse bleeding due to fall on the road. Bleeding not stopped easily. Child rushed to the hospital where lab study shows normal platelet, PT and APTT slightly increase associated with high TT. I will tell you later. Now see, TT is increase. When only TT is increased, defect in fibrinogen. It is afibrogeniemia. It is afibrogeniemia. So am I clear? This is the classical question. What you need to remember? TT increase. TT increase. High TT. Thrombin time is increased. So it is fibrinogen defect. It is afibrogeniemia. It is afibrogeniemia. Am I clear? Answer this question. Take your time, read question properly. Yes, Priyanshi, Divya, Nisha, Arita, you all are right. Swatik, but read this question and try to make the answer. Divya, is it for every exam? But previously, now we are targeting FMG. So FMG most important questions. Yes, if you are a NEET PG aspirant, this question is as good. If you are an intern, you are a final year student, this question are good. These are must know MCQs. Sometime when we read the topic, these are missed. I will cover some tough MCQ later. A 15-year-old girl developed massive bleeding from the wound side 36 hours after the large cyst removed. So it is late post-operative bleed. Bleeding continue. All measure to control bleeding was unsuccessful. PT, APTT, TT, platelet count, everything's turned to be normal. Every investigation normal, but bleed continue. So what you are thinking? When bleed continue, PT, APTT, TT, platelet count, everything is normal. We may have factor 13th deficiency. We may have factor 13th deficiency, which is diagnosed by urea clot lysis test. Urea clot lysis test. So clear na? So yeah, this clotting factor, this is the approach for a coagulation disorder. And trust my feeling and concept, you may get question on this, which we normally miss it when we read the hematology. We read the platelet disorder, ITP, Bernard-Schuyler syndrome, Glanzmann thrombocythemia, Wiskott-Eldridge syndrome in detail. But coagulation disorder, we miss it. Hemophilia, von Willebrand disease, it's a bleeding disorder, we miss it. So it's the concept. Only PT prolong, factor 7. APTT prolong, 8, 9, 11, 12. 12 deficiency, no bleeding. Both prolong, 2, 5, 10. Only TT prolong, afibrogeniemia or dysfibrogeniemia. All normal, but bleed continue. Factor 13th deficiency, diagnosed by urea clot lysis test. And these two are the classical question. These two are the classical question on approach to coagulation disorder. Answer this question. Simple question, na? You know, hemophilia A and B, eighth deficiency leads to hemophilia A. 9 deficiency leads to hemophilia factor 11th deficiency, hemophilia C. So, if hemophilia A is due to factor 8 deficiency, hemophilia B 9 deficiency, hemophilia C 11 deficiency, and parahemophilia deficiency of factor 5. Deficiency of factor 5. So you should remember one more thing about hemophilia. Hemophilia. It is X-linked recessive disorder. What it means? Only boys are affected. Girls are carrier. Girls are carrier. Hemophilia, it's a X-linked recessive disorder. Only boys are affected. Hallmark of hemophilia, hemarthrosis. Hemarthrosis. Okay, so which is the earliest joint in which bleed occur? Earliest joint. In bleed occur in hemophilia. I want answer in comment box. It's elbow, shoulder, ankle or knee. Earliest joint. Yeah, I was expecting this answer, Divya, but it's not knee, it's ankle joint. Ankle joint is the earliest joint in which bleed occur in hemophilia. In which bleed occur in hemophilia, it is ankle joint. So you should know something about hemophilia. Okay, now read this question. Try to give an answer. If you read this and use some common sense now, you will be able to answer. Then I will teach you some very good concept. Some very good concept. Take your time, 30 seconds. Any? No answer? Now see. Yeah, Amit, you used your common sense and get the correct answer. A male infant found to be jaundice at 12 hours after birth. 12 hours after birth. Now everybody putting the right answer. 12 hours after birth. So think jaundice within 12 hours. Pathological jaundice. What are the causes of jaundice in first 24 hours? FIRST. First day jaundice. F. Feto-maternal incompatibility. ABO and RH. I. Infection. R. RBC enzyme deficiency. G6PD and pyruvate kinase. S. Spherocytosis. And T. Thalassemia. Which thalassemia? Alpha thalassemia. Jaundice in first day of life. Now, we read the question. Bilirubin 18, hemoglobin 12.5, retics 9%. Means it's a hemolytic anemia. Some spherocytes present. Answer can be pyruvate kinase deficiency, RH incompatibility, but not sickle cell anemia. Sickle cell anemia not causes jaundice within 24 hours. But what is the clue here? Make this question easy. Spherocytes are present. So RH incompatibility, no spherocytes. Pyruvate kinase deficiency, no spherocytes. Spherocytes present. It indicate hereditary spherocytosis. Hereditary spherocytosis. Now see, what are the other condition in which spherocytes present in the PBF? A table from the Nelson. What are the condition in which Spherocyte present in the PBF. Spherocyte in PBF. Hereditary spherocytosis. You all know. Autoimmune hemolytic anemia. So first is hereditary spherocytosis. Second is autoimmune hemolytic anemia. Autoimmune hemolytic anemia. Third is ABO incompatibility. Fourth, G6PD deficiency. Fifth, Wilson disease. And next, burn or hyperthermia. Hyperthermia or burn. This is an MCQ. Burn, hyperthermia, spherocytes in PBF. Wilson disease, spherocytes in PBF. So what you notice here? What you notice here? See, spherocytes are there in ABO incompatibility, not in RH incompatibility. In G6PD, not in pyruvate, not in pyruvate kinase deficiency. Pyruvate kinase deficiency. So now our question is very clear, na? See, jaundice within 24 hours, spherocytes in PBF, it can't be pyruvate kinase, it can't be RH incompatibility, because in both these situations, no spherocytes present in the birth. So with this question, what we remember? Causes of jaundice in first 24 hours, causes of spherocytes in PBF. Remember this. Wilson, burn, hyperthermia is a cause in which MCQs comes. So these topics we not read normally. These are must know MCQs. Must know MCQs. Spherocytes in PBF. Answer this question. Big MCQ. No need to afraid. Read it carefully. Spend at least 1 minute in reading the question and MCQ. You will able to answer, and I am waiting for your response. Yes, Pavan, Divya, Shivani, Priyanshi, Nisha, Anil, Vikram, Anmit, you can answer. Arita, you can answer this question. Take your time, 30 seconds, silence. Arita put A answer. At least Arita tried. Okay. Vikram A. Okay. Anil also put A. Priyanshi D. Okay. I will take 5 more answers. Pankaj put D. Transient erythroblastopenia of childhood. Raj and Amit also put D. Okay. Now we come to this question once again. Just what is diamond black fan anemia? It is pure red cell aplasia. It is pure red cell aplasia. Congenital. Most of the patients of diamond black fan syndrome diagnosed between 2 to 6 months of age. Classical feature, only RBC cells involved, only RBC series involved. So they have very low hemoglobin. Despite low hemoglobin, retics are 0%. Why retic 0? Because it's bone marrow aplasia, pure red cell aplasia. It is congenital pure red cell aplasia. Black fan anemia manifests between 2 months to 6 months, characterized by low hemoglobin, retics 0. Three classical lab findings of diamond blackfen anemia. Three classical lab findings. Fetus hemoglobin F increase. MCV increase. RBC ADA increase. Adenosine diaminase. So these three are classical. Hemoglobin F increase, MCV increase, ADA increase. If somebody is having diamond blackfen anemia, hemoglobin 4, 5 within 3, 4 months, retic 0, you do the bone marrow, only RBC reduce. No retics, 0. So it's diamond blackfen anemia. How child survive with 2 milligram, 4 milligram hemoglobin? Yes, we need to start steroid in the treatment. 2 milligram per kg and come down on steroid. More than 50% respond to steroid. So their bone marrow shows precursor and hemoglobin become normal in 4 to 6 weeks. If steroid fail, then we need to increase hemoglobin by transfusion. If still not, 5 to 10% needs stem cell transplantation. So diamond blackfen anemia, classical, pure red cell aplasia. Hemoglobin low, retic 0. F increase, MCV increase, ADA increase. Treatment is steroid. It's a congenital. So come to the question. A healthy 2-year-old child, it can't be diamond blackfen anemia. RBC adenosine deaminase levels are normal. ADA normal. ADA normal. So it can't be diamond blackfen anemia. Now, Pearson Marrow Pancreas syndrome. This is also known as congenital sideroblastic anemia because PBF and bone marrow shows ring-shaped sideroblast. So congenital sideroblastic anemia. Anybody can tell me inheritance of Pearson Marrow Pancreas syndrome? It's X-linked dominant or autosomal dominant or X-linked recessive. What is the inheritance of Pearson Marrow Pancreas syndrome? Anybody? Inheritance. I am waiting. Yes, it is mitochondrial inheritance. It is having mitochondrial inheritance. Now see, transient erythroblastopenia of childhood. So RBC or hemoglobin transiently low due to some viral infection. The most common is parvovirus B19. Parvovirus B19. RBC and hemoglobin precursor low. Transient. Whatever, the child is good at 1.5 year, 2 year. Suddenly they have attack of virus and their hemoglobin comes down to 4, 5. Sometimes they diagnosed, but sometimes remain undiagnosed. Then recover itself. So now see the question. See the previously healthy 2-year noted pale by the parents. Bring to her your clinic. No fever, no bony pain, no other complaint. Pallor, tachycardia and murmur due to anemia. CBC reveal hemoglobin 4. Normal WBC platelet counts. Retics is 0. Coombs test is negative. So no hemolytic anemia. Hemoglobin low. Retic 0. It's red cell aplasia. But look at what is the age. 2 year. So it can't be diamond blackfen anemia. It can't be Pearson Marrow Pancreas syndrome because PBF show no ring sideroblast, not given in the question. Then ADA levels normal. ADA levels normal. So what is this? Transient erythroblastopenia of childhood. So remember my friend, all these things. These are the MCQ. Clue, 2 year. It can't be diamond blackfen anemia. Diamond blackfen anemia is congenital pure red cell aplasia and transient erythroblastopenia of childhood is acquired pure red cell aplasia which is caused by parvovirus 19. So remember this type of question in hematology also. We are covering some questions which normally we not read. This is one of them. Diamond black vein anemia, hemoglobin F, MCV and ADA increase. No fever. Yes, no fever. If fever is there, it suspects some leukemia or some immunodeficiency may be there. Some WBC series also decrease. When WBC platelet normal, to wild fever. Just a attack of viral illness, no fever, which involve mainly the bone marrow, aplasia. That's all. That's all. Okay. That's why sometimes they remain unnoticed. If parents are vigilant, they pick the child is looking pale. It's a transient condition. As viral things over, hemoglobins again reaches to normal. It's not a congenital deficiency, it's acquired things. Okay? Answer this. Answer. 8-month infant noted to have platelet count 35,000. When there is low platelet and you find hemangioma over body. Low platelet and hemangioma over body, whether hemangioma over face or retroperitoneal, but low platelet with hemangioma, it is Casa-Beck-Merritt syndrome. Casa-Beck-Merritt syndrome. So yeah, Casa-Beck-Merritt syndrome, diamond black vein anemia, transient erythroblastopenia in infancy, Pearson Marrow syndromes. Then causes of spherocytes in PBF, causes of first day jaundice, approach to coagulation disorder, afibrogeninemia, urea clot lysis test. You agree, na? These are the must know question for pediatrics, and these are we are not reading in day to day. So yeah, something else, something good. So this 20-25 minutes attention may give you one question or one concept in the exam. So I tried my level best in these two sessions. Those who missed first, you can watch on the YouTube again, and this is the second which we have taken today. Now just after 30 minutes I am coming must know MCQ in pediatrics on Unacademy app, and this is a special class. So anyone can see whether you are Unacademy Plus subscriber, yes or no. Anybody can see. It's a free class, a special class. I try my best effort to give you some good MCQs on Unacademy app at 9 p.m. So don't miss. Now this is something me and ma'am. Okay, so coming with the integrated session in biochemistry, amino acid metabolism, carbohydrate metabolism, phenylketonuria, alkaptonuria, tyrosinemia, galactosemia, fructosemia, all concept to be clear, clinical treatment and raw biochemistry. It's an integrated session, but this is for plus students. And this is the course which I am continuing, FMGE. So 2 sessions are remaining, metabolic disorder, respiratory, GIT and nephrology. So be there, those who are plus student at 7:30 a.m. morning. So just wait for all of you just after 25 minutes on Unacademy app. This is the class. Must know MCQ in pediatrics, and I will not disappoint you. I will bring some very good MCQ for you. So keep reading. Let's crack it. If you like this session, share with others so others can also be benefited from them. This session. Thank you. Bye bye. God bless you all. God bless you all.